Hey guys, it's Howie, and I should be looking here, huh? And I am so busy with grad school and my new job at the ICU, and that I haven't had time to use my fancy camera. So now I'm on my break, giving you guys an update on how I'm doing. Well, currently, as you guys know, that I am a psych nurse practitioner student, but I'm also an ICU nurse. Currently, I don't think my ICU is that acute, and I've been told that. They said, you need to go to an ICU that's more acute, but I'm actually kind of feeling good about going to a less acute ICU. It's what they call an LTAC. As contrary to what people say, they get really unimpressed when you mention LTAC, because basically when a patient's insurance runs out, they basically come to us. It's a for-profit hospital. And so we basically have to have the best continuation of care from wherever ICU that their patient is stabilized from, and then it gets transferred over to us. But I actually don't mind having maybe just like 3 or 4 or even 1 or 2 critical care drips. And by this, I mean, many of the ICUs, to be termed an actual ICU, is that you have to have critical care drips that are usually titratable. And these involve pressors. For example, Levophed, which is a norepinephrine. And, patients need that, for example, if they're so far along in their congestive heart failure that they need these medications to pump their heart for them. There's also sedation medications such as propofol, the same one that killed Michael Jackson. I love Michael Jackson. And those are very, very high risk drugs per se. And also some 3% normal saline. And you wouldn't think that 3% normal saline is that terrible, but it can suck out a lot of the fluids from your body very quickly. So it's dangerous. And so these are very high risk medications, higher risk than diabetes. And you know what? You can pretty much essentially count on your patient being diabetic, or at least having some kind of metabolic or insulin hindrance in their comorbidities. Other stuff too is that they're almost always on heparin. They're almost always on antibiotics, and they usually have UTIs. These patients can't move, they can't talk. The other thing is, besides critical care drips, is vents. Ventilators, usually run by respiratory therapists, are the main reason why ICUs were invented. Basically, patients couldn't breathe anymore. Back in the day, before iron lungs were made to breathe for the patient, patients just died. So now that a machine was invented to make the patient breathe for them, make the machine breathe for the patient, is when ICU was born. And then critical care drips came along with it, and then everything else that's wrong with the patient. Usually it's multifocal and very high risk, which is why intensive care units are intensive. But I mentioned that I started doing, ICU full time, and they pay well, they pay great. But, there's little bits of jealousies of people who have been in ICU for a long time. Some of them are still not. They're still reticent to take on a student, while there's other nurses on other floors, and they're like, oh, well, Howie's ICU, so he thinks he's better than us. I absolutely do not think that. I even respect janitors, CNAs, because they help me do my job to care for the patient. So I absolutely don't care. I do love the fact that I'm working in an actual tiny little ICU within the LTAC. So we stabilize the patients before they go out into our floor. Even though they may not be as acute as when they first presented to the previous hospital, they're still acute patients. And, I'm very proud of that. I did take a couple of preceptors. It's too bad that I have different preceptors, but now I have one main one, and she's amazing. A couple of the nurses have been there for like 20 years, or been nurses for 20 years, and they're kind of like retiring, so they wanted to go to an ICU that was a little bit less acute. And but I was lucky enough to attach myself to a younger, I think she's younger than me actually, and more experienced ICU nurse who knows more about that stuff. And she is legit She's from Alabama, and she was on a trauma unit, and she's legit ICU, as in she makes sure that all the lines are labeled and organized, and medications are given on time, and medications critical thinking are they're challenged, well, not challenged, but orders are clarified with the doctors right away. So very OCD-ish, which is why I'm glad that I link myself up with her. But one of the things that's really sad is that she kind of more or less gave me the hint that she won't be in the unit for very long. And what I'm taking is that she came in from Alabama, got to this hospital, and then realized it wasn't her deal, and is probably looking for another position. So I've only been with her for a week, but she's so good. She's taught me more than any other nurse on that floor. And I hate to see her go, but she can't talk any more details about it. So I'm just going to have to relegate myself to trying to learn as much as I can from her. So that's my update, you guys. Things are great because I don't have to worry about things financially for a while. But I may start to continue to go to school as a psych NP, but the CRNA friend of mine has been interested in kind of mentoring me and then possibly getting me into a program. I don't know about all that. I feel like that's a distant dream, because I kind of relegated myself to just psych NP, which I love psych, by the way, and psych NPs are great, but it's, that's where I am right now. Okay, so thanks a lot for tuning in. I'm sorry this is crappy video, but Nurse Howie out.